Dr. Henry mentioned the possibility of shrinking the interval. Do we know how soon that decision could be made, especially in light of there's one study out of the UK that found that a single dose of Pfizer may not be enough to protect against the variants. And of course, there's individuals who are going through chemotherapy or who are concerned about the 4-month delay because they're afraid that the one dose does not provide enough protection. So what has influenced the decision to shorten that interval, and how much shorter could it be?
So we've said from the very beginning that the interval was a maximum of 4 months, and it was based on available vaccine. And the strategy that we're using, based on the evidence that we have and the modeling and all of the data that we have, is that it is better for all of us to get more people protected with a single dose than to focus on getting everybody protected with 2 doses, because the incremental benefit for an individual is quite small. And that study in the UK showed this as well. What it showed was that healthcare workers were well protected after a single dose and protected against the variants that were circulating at that time. Which were different than what we're seeing now. That study also showed that people who had an infection prior, so whether it was even an asymptomatic or a mild infection, mounted a stronger antibody response. So the first dose of vaccine really to them acted like a booster dose. What we don't know, and what the challenges that the authors of that study brought up, is we don't know if that level of response would be the same for some of the newer strains of the virus that people are being infected with right now. So that's the information that we continue to look at, and how we look at that is by following the vaccine effectiveness over time. So if we start to see breakthrough cases in people because of different variants, for example, because of the virus they're infected with. So that's what we're doing here in BC. The BC CDC has been following very carefully healthcare workers, and we compare healthcare workers who are immunized versus non-immunized and see if we're starting to see breakthrough cases. And so far that has been very small. And also we look at, we've been looking in long-term care homes as well to see in those settings, are we seeing increased numbers of cases in people who, if one of the newer strains of the virus is introduced into those settings. And so far, we continue to see very good protection from a single dose, as they did in the vaccine effectiveness in the UK. So what we are looking at is once we get every adult to that point where we have high levels of first dose, then we can start to decrease the interval for second doses. So as I said, people who were immunized early on, they're now getting their second dose, and as we go into May, that increases in numbers of people. And for those who were immunized, healthcare workers, people in First Nations communities, where we did a whole of community, we have taken those vaccines off the top for second doses, so you will get them at the very latest by 4 months. But we also know that with the amount of vaccine that we have coming in the next 2 months, many people who received their first dose in the last few months will not have to wait for 4 months. And we are looking at the data of how we do that over the next few weeks. So I know that sounds confusing, but it is exactly what our whole strategy has been about, getting as many people protected as quickly as possible, and particularly moving up the line those who were most at risk. But as we're into this phase and we can open up more vaccines for more people, we'll be able to start the second doses for more people sooner.